Good afternoon, everybody, and welcome to this webinar looking at synthetic opioids, with a particular focus on how the drug and alcohol treatment sector and wider system partners actually need to work differently to respond to the change in drug supply. My name's Clare Taylor, and I'm the Chief Operating Officer at Turning Point. And I started my career as a volunteer in a needle exchange in Liverpool back in the 90s. And I've been passionate about reducing harms for people who use drugs since then. This webinar is the third in a series of 7 health and care future webinars taking place over the next few weeks. As part of a programme of activities to mark Turning Point's 60th birthday. And they're really aimed at stimulating thought and conversation around important and pressing matters affecting the people that we support across Turning Point. Thank you in advance for joining us. We've got a fantastic panel with us today to start this discussion. We've got Michael Linnell, who I know a lot of you have probably heard of, who wrote the national guidelines for the local information systems, which were published back in 2016. And Mike runs a number of the local systems across the country which assess and share information about the local drug supply between partner agencies, issuing warnings where needed. He also coordinates the UK and Ireland Drug Watch, as well as being a talented artist specialising in design to support harm reduction. We're also delighted to be joined by Deb Hussey, who is the National Safer Lives lead here at Turning Point. And Deb has really spearheaded our strategy to reduce drug-related deaths with a focus on increasing naloxone awareness, distribution and carriage across our services. Deb is passionate about involving people with lived and living experience in the development and delivery of services across Turning Point and the wider drug and alcohol sector. Just before we get into the discussion, just a few points of context. So in the UK, the rise of synthetic opioids has dramatically changed the drug market in such a short space of time. Synthetic opioids such as fentanyl and nitazines are laboratory-produced drugs that mimic the effects of natural opioids such as heroin, but can be much more deadly. The Taliban banned the growing of opium poppies in Afghanistan back in 2022, and as a result, production has reduced by about 95%. And with the majority of European heroin supply coming from Afghanistan, this level of reduction has had a massive impact in the UK heroin market in terms of availability, cost and purity. Nitazines have been detected in heroin, but also in other drugs, including benzodiazepines, which means a far wider group of people are at risk of accidental overdose than in the past. And it was only on the 3rd of October data was released from the government saying that 179 deaths involving one or more nitazines occurred between June 23 and May 24. So today's webinar is really focused on the question around how do we, as providers and the wider system, need to work differently to respond to this challenge. I'm going to ask Mike and Deb to make some opening remarks and to share their thoughts with us. And then we'll then go to questions from the floor from you, starting with perhaps one from myself, if I can. And as the session proceeds, if you do have any questions and comments, please add them to the Q&A button that you'll hopefully see at the top of your screen. If you click in it, you can type your question. If you can please say who you are and where you come from, that will help. And you can also respond to other people's comments. Just because of how the webinar set up, you won't be able to ask the question yourself, but we are monitoring that and we really do want your questions to so that we can have a full discussion. So I am now going to pass over to Mike, who will share his thoughts with us. Thank you, Mike.
Thanks, Claire. As Claire just outlined, at the moment the drug markets have probably never been more dangerous, and I think it's important to not just understand what the drugs market is at the moment, but the characteristics of the people who are most at risk. It's wider than just people who are in treatment for heroin use or people who are using heroin. We've already had cases of people who are not in contact with treatment services, who are self-medicating, who are buying opioids online and benzodiazepines online to treat various ailments. and they've, as Claire said, they've been adulterated with nitazines. It's got quite a bit of publicity at the moment, nitazines. There's I think up to about 33 different nitazines have been identified of varying kind of potency, and it's always quite difficult to imagine. But the point about these were that they've never been used commercially. They were developed in the 1950s, but they never went into commercial production because they was considered too dangerous. In terms of the characteristics of the group most at risk, that i.e. the people who are at risk of dying, it's no coincidence that the people who use heroin tick just about every box that you could possibly imagine. Childhood trauma, the likelihood of them spending time in care, time in prison, time rough sleeping, etc., etc. Diagnosed and undiagnosed mental health issues, and this is an aging population already in poor health, which is one of the factors that's led to the kind of record drug rises we've seen over the last decade. There's about 5,000 drug poisonings a year. The majority of those, when they take into consideration those that are not put down as drug misuse, are probably to do with drug misuse. And the biggest category are those who are using heroin and other opioids. Deaths are very rarely involving just one drug. It's nearly always a combination of drugs. So it will be heroin, quite often crack cocaine, benzodiazepines like street diazepam, and pregabalin, drugs like that. At the moment, the street market for fake benzodiazepines is particularly dangerous in that you can buy a box of 10 milligram diazepam that's got the manufacturer's marks on, comes in a blister pack, and invariably at the moment they can contain bromazolam, which is 10-20 times the kind of potency. And we've even found fake street benzos that have got bromazolam and one of the nitazines in them as well. So it's a really kind of dangerous market. Affects a wider group of people, but the predominant group of people are heroin users of this aging population of heroin users. In terms of a response, the response didn't come out of the blue. This is something that's been going, each new wave of drug use that we've seen, each new deadly threat, if you want to put it in newspaper terms, has led to a response from the drugs and wider field. The major response that we've got at the moment is, firstly, it's intelligence driven. So unless you actually know, what you're dealing with, what drugs are on the street, what people are doing, then your response is going to be limited and you're likely to make mistakes. It's also important that it's a multi-agency response as well. So the ELDIS system, one of the things about nitazines is it's pushed those areas that haven't got an existing ELDIS system to put one in place. The one we've got in Greater Manchester, we piloted it there back in 2014, so it's been going for a longer time. And it worked, it operates very successfully. So we've got about 1,000 professionals in a network who are kept up to date for information. If somebody reports to me that they're seeing, X drug in particular area, you can get an instant trend research by sort of saying, is anybody else seeing this? What's kind of occurring? We also have an alert panel. So when incidents occur, we get a multidisciplinary alert panel who can investigate. And that includes being able to test drugs for public health purposes. This is either drugs that the police have seized or drugs that can be handed in by professionals and then tested for public health purposes. Even evidential samples can, for if there's an extreme public health need, can be split in the kind of system we've got. As I said, the ELDIS model is happening in other places, but that drug testing is one element that I think is being sorely missed. There are a number of initiatives. The Loop have recently set one up in Bristol, which is a slightly different system in terms of their home office license, where there's a kind of pop-up lab where people can go in and get their drugs tested. The Public Health Wales have got a system where you can send drugs in, although this takes some while to get them tested, and they don't do dosage, which is quite important as well. So, for instance, I mentioned bromazolam, which is much stronger than diazepam, but if you don't know how much is actually in a tablet, it's difficult to work out if it's, you know, if it's far more dangerous. There are also some drug checking schemes are going to be developed in kind of Scotland. So in terms of the local system, the eldest model works. It's a simple system and it's an intelligence-based system. Producing a warning and stick a poster on the wall is not the idea of it. There may be instances where you want to do that, but in most cases it's looking at an effective response and what you can do, making sure that professionals know what's going on. In terms of other bits of an effective response, the Scottish system has recently been set up called Radar, where they've looked at gathering wider intelligence, you know, for instance, in terms of the number of non-fatal overdoses and the number of times that naloxone, which is an antidote to a heroin overdose, have been used. And a system kind of mirroring that is recently been set up in England, which is gradually being kind of developed. And woo, yesterday we got the pilot for Northwest Ambulance Services, where they are recording the number of non-fatal overdoses and collecting that. Came in for the first time to our kind of services that we were able to see. So, for instance, if you've got an idea of, you know, if you suddenly get a spike in overdoses, you would have an impression that something's going on. There are gaps in intelligence in terms of an effective response. Coroners is one of them. Some coroners are very good and they do cooperate and share information. Others not so much. So it's not just about testing the drugs after somebody's died, but sharing information quite rapidly when kind of incidents happen, sharing toxicology, that kind of information. In terms of the NHS, again, this is something that this current crisis is kind of pushing, but we've seen recently, you know, a couple of issues, you know, one of them being the damage caused to the bladder by ketamine use, and you will often see you know, an A&E consultant go on Twitter or wherever and say, we've seen an explosion in this. What does explosion mean? From what number to what number? We just haven't got a way yet to get that data from the NHS. So as I said, things are improving. Those kind of models are there in terms of intelligence. One other thing that has happened as well is that every local area now has a synthetic opioid plan. Well, they should. I think the deadline's the 31st of October for them to have them. So this is a kind of, again, a multi-agency response in what you do. Primarily, the what you would do is you would ensure that, you know, people have got naloxone, and I mean that's been rolled out. Both in terms of professionals carrying it, there are a number of police forces that are carrying it now, but more importantly for people who are at home, so they can, drug treatment services can prescribe it to the friends, family, you know, people who are injecting with. It's not perfect by any means, because one of the issues is that people often die alone. In fact, the majority, as far as we're aware, of people actually die alone. So there are a couple of initiatives that are being tried with that as well. You know, kind of smart apps and sort of buddy apps and telephone systems are being trialed. One of the things that the previous government resisted for spurious, ridiculous kind of reasons was that in certain situations where you've got a high percentage of people who are using and living in a city centre, you know, rough sleepers, etc., that you should have a safer injection facility there where, you know, famously nobody's ever died injected in a safe injection facility. This is somewhere where people can go, they can inject their heroin, etc. And there are professionals there with naloxone to make sure that if people do overdose, etc. So, I mean, there's one plan to open in Glasgow fairly soon, but I mean, I think that isn't the solution for everywhere, but where you've got those high concentrations of a population in the city centre using, I think that's one thing that we could work on as well. In terms of, as I said, naloxone, at the moment, it's only drug treatment services who can prescribe it to kind of take home. And there is some legislation that was on the record books, through the previous government. Hopefully that will come about so that a wider group of professionals can actually prescribe that as well. So in terms of the response, I don't think you'll ever get a perfect system where you've got this, aging, 44 years plus population. Quite often they've been using for kind of decades as well. Quite often they're in kind of really poor health anyway, and they're using really, really dangerous drugs. You're going to get deaths. I mean, this is about developing the best system. I don't think with the best will in the world we'll pretend that we're going to solve this problem by not having any drug deaths. In terms of what will happen, as I said, this is an aging population of heroin users. Young heroin users are as rare as hen's teeth. There's something like an estimate of 340,000 opiate users in England and Wales. There's under 50 in treatment who are under 18. Only about 25 of those are, actually that's their kind of drug of choice sort of thing. And you can guarantee they hit all those kind of, boxes I mentioned earlier. So the drugs may change, the kind of markets may change, but the most at-risk group will remain, the poorest people in society, the people with all the kind of existing problems, and from the areas of the biggest deprivation. And it's no coincidence that it's the further north you go, the greater the drug deaths. What you do about that, I think one of the things that you can do about that is trying to reduce the stigma that people face by engaging with more generic health and welfare kind of services anyway, which is a major issue that people identify. But as to how you kind of solve it, I mean, you having a kinder, better, more equal society would be the ideal, but I don't think we're bringing it back to Turning Point. I don't think we're any nearer that than we were 60 years ago when Turning Point was founded.
Thank you, Mike. I'm sure lots of people are holding questions. If people can post them in the Q&A, when we've moved over to Deb, we will pick those up. So please, if you have got a question for Mike or Deb or just a comment to make, please do share it in the Q&A panel. So we'll move on next to Deb. Over to you.
Hi, everybody. I've been asked to do some challenging things since I came to work at Turning Point. Following Mike has got to be up there with them, I have to say, but I'll do my best. So my name's Deb Hussey. I'm Turning Point's Safer Lives lead, and what my role involves is supporting Turning Point's harm reduction strategy, but my main focus is on widening accessibility and availability of naloxone and developing interventions to reduce overdose deaths. So as this webinar is part of a series of events to mark Turning Point's 60th anniversary, I thought I'd start by looking back a bit. I'm not quite old enough yet to be able to go back the full 60 years, but my first experience of the drug treatment sector began almost 30 years ago. Although back then my view was from the other side of the garden gate. So I was someone who was dependent on heroin for many years. And I was a beneficiary of many of the early innovations that we saw come out of UK harm reduction, the home of harm reduction as far as I'm concerned. And because of those innovations, I had access to sterile injection equipment. I was never exposed to HIV. I had overdoses reversed by naloxone, which I know I'm biased, but possibly the greatest innovation that we've seen so far. So this sector has a really proud history of rising to the challenge of a public health crisis, and it's always evolved and innovated to meet each new threat. So we need to draw on that now because we know we can do it. So I first became aware, as probably a lot of people did, of nitazines in the summer of 2021. So I just started with Turning Point then, and we received a report that there was a cluster of overdoses in the southeast linked to a substance that no one could pronounce, and I still can't pronounce it now, so I'm not going to say it. But we called it ISO, and it turned out it was from a group of potent synthetic opioids, collectively known as nitazines. And all we were really told, there was very little sort of intelligence. You know, Mike was talking a lot about how our response to this needs to be intelligence driven, and there was very little intelligence. But what we were told is that people that had had overdoses reversed where ISO was involved had needed multiple doses of naloxone. And that kind of cluster of overdoses came and went, and we didn't hear any more about it. So somewhat naively, we thought it had gone away. Obviously, we all know now that wasn't the case. So then in the summer of 2023, we saw multiple overdoses and deaths linked to nitazines in the West Midlands and some I live in the Southwest, and there were a cluster of overdoses in Bristol. So the first thing we did was the only thing that we knew, which was we needed to give out more naloxone. So we doubled up on all the naloxone we were giving out at Turning Point, as I know a lot of other treatment providers did, ensuring anybody that used opiates had a minimum of 2 kits. And since then, it's been a learning curve. But what is clear to me, as I'm sure it is to a lot of people, is that harm reduction has never been more important than it is now. In April of this year, our service in Leicestershire found out firsthand what happens when synthetic opioids enter the local drug supply chain. In the space of 24 hours, there were 22 overdoses, and sadly, 4 of them were fatal. I mean, that's just the ones that we know about. You know, there were possibly many more overdoses that weren't reported, that people didn't go to hospital, and this all happened over a weekend as well. So luckily, the service in Leicester already had a WhatsApp group and were prepared to coordinate outreach and support outside of normal working hours. And I feel really confident in saying that without that response from the team in Leicestershire, the amount of overdoses and possibly deaths would have been much higher. So we took our learning from Leicestershire, and that led to the development of what I think I called it the staged response plan. I can't remember. It's had a few titles, but it's what Michael described as the synthetic opioid plan. So yeah, we have one, and it's a template for all our services to assess local risk and plan their response accordingly. But I was thinking about what else services need to do. So we have all of this stuff in our plan, but is there anything that's not in the plan that we need to do? So we know being in treatment is a protective factor, and for people using opioids, being on opioid substitute treatment reduces their risk of overdose, and it reduces their chance of a fatal overdose if they do overdose. But to get more people into treatment, we need to make our services places where people want to come. So, you know, we need to challenge stigma. We know that disproportionately affects people that use drugs. We know that can prevent people from seeking treatment. But we also, you know, need to make the environment better. We need to make it, this isn't my quote, this comes from someone much cleverer than me, but they said we need to make it easier to get in, to stay in, and to get back in if you need to. So we need to develop and deliver services that meet the needs of the people that they're for, not with a focus on goals that we've chosen for them. And you're going to hear me say this a lot, we need to reprioritise harm reduction. For far too long, it has been seen as that add-on, and in some cases, even as an inconvenience that gets in the way of our real jobs. I hate doing that, but it's the only thing I could think of to explain what I'm saying. But, you know, I'm sure you're all aware, with the introduction of the recovery agenda, services were really forced to narrow their vision and focus on a single outcome, which was abstinence. Harm reduction services were decimated, funding was reduced or withdrawn completely. And the problem with having a singular focus is it fails to acknowledge that people use different drugs for different reasons. In a way, it kind of homogenized drug use and created a one-size-fits-all pathway. Thankfully, we're starting to find our way back from that, and there's so much fantastic work being done. Within Turning Point, we have a really strong focus on harm reduction, and that is increasing. You know, I'm given so much opportunity to develop new harm reduction interventions within our services. I do tons of work, not to blow my own trumpet, but I do tons of work at widening availability of naloxone. We have a click and deliver service. It's the only one in England that we're rolling out across all of our services. We've developed some naloxone training specifically aimed at young people who might witness an overdose, and that has kind of evolved as we've been developing to look at the risk that a lot of young people are at because of synthetic opioids, because like Mike said, it's not just opiates that they're turning up in, it's you know, benzos, it's drugs that young people might buy on the dark web. We've adapted our overdose prevention messages. We've introduced the use of test strips, as I know a lot of services have, but we've introduced them as part of a full harm reduction intervention and a staying alive plan, which is based on, I have to make sure I get this right, it's based on a plan developed by the Northwest Fatal and Non-Fatal Overdose Task and Finish Group. Say that when you haven't got your teeth in, but it did involve input from people that use drugs, which I think is really important. So we've done all of that stuff, but we still got work to do. And to be clear as well, I'm not saying there isn't a place for recovery. Like, you know, abstinence is the ultimate form of harm reduction, but we just need to acknowledge that recovery isn't an option for everyone, and we need to have an equal focus on services that help keep people safe. There are lots of things we do really well. It's just really important that we don't get complacent and we acknowledge that there's always room for improvement. Turning Point has a long 60-year history of adapting and innovating to meeting the needs of a changing landscape, and I'm sure we'll continue to do that. But we need to see change and innovation at government level too. As Michael's already said, we need to be able to open overdose prevention centres where they're needed. We need to implement more city centre drug checking services. I say more, we have one. So it'd be quite hard to have less. I'm really lucky, I live in the southwest. So, you know, like Michael already said, the Loop run a monthly city centre drug checking service, but that's one, and that's once a month. And the reason we can't do those things is because we're operating within legislation, the Misuse of Drugs Act, which was put in place over 50 years ago. To me, that seems bonkers. The world 50 years ago was such a different place to what it is now. But an even simpler ask, and I think Mike mentioned that as well, is we need the promised update to the legislation that'll allow for the wider distribution of naloxone, and that needs to be pushed through as a matter of urgency. So speaking to the sector as a whole, in this area of our work, where our primary focus is saving lives, we must be careful not to gatekeep. In a climate where organisations are in direct competition with each other, the commissioning system literally pits us against each other. We need to ignore commercial sensitivity. When it comes to saving lives, there should be no competition. We should no longer be working in silo. What we do well, anything that proves effective in reducing the harms of synthetic opioids, we need to be promoting it and we need to be sharing it with each other. And where possible, we need to go one step further and collaborate. I'm so proud of the work that I've done with my harm reduction colleagues from Cranston, from CGL, and I know some of them are on this call, from Humankind, from HIT. You know, the work we've done getting messages out to people to reduce their risk of overdose from synthetic opioids. You know, I'm so proud of it. And I'd love to see more of these kinds of collaborations. And we also need to collaborate with the people who are most at risk. When we surveyed people who use Turning Point services in Somerset, we found that 3/4 of the people we spoke to had witnessed an overdose. We need to be empowering those individuals to support the people that are around them, because they're best placed to share harm reduction messages to people who trust what they say more than what we say, and they're there at times when those messages are most needed. we're not going to reduce these avoidable deaths on our own. We all need to be working together to do it. So before I stop rambling on like a nutcase at 4:30 on a Friday who's drunk a lot of coffee, I just want to read you a quote from someone that was supported by our service in Leicestershire at the time of the cluster of overdoses linked to nitazines. So this is what they said. They said, "We have friends and relationships just like the rest of you. Some of us have had the same buddies for 20 years plus. We've been through a lot together. I don't want to see people die." And I'll leave you with that thought.
Thanks, Deb. That's a poignant saying to leave us with at this point. And we have got quite a few questions that have come in, so we'll get round to those. Please keep posting them, by the way. We've got about half an hour, so we've got time to get through some of the questions. But I wanted to take Chair's prerogative, I guess, first and ask a question myself, which is, we've got a really broad range of people on the call today, which is great. We've got providers, we've got people from lived experience organisations, housing, police, probation, academia, local commissioners, which is great. And I suppose it talks to the conversation around multi-agency working and multi-agency responses. And what really enables that in a system? What are some of the key things that really enable multi-agency working, and what are some of the things that might get in the way? You talked, Mike, about Greater Manchester. I wonder if that's an example of good practice that other areas could learn from.
In short, yes. I mean, we just launched.
Any of the sort of key factors that really, I suppose, enable it?
Well, I think one of the at the launch, Andy Burnham, the mayor, was talking, and he was asked the question about combined authorities, and I think there is combined authorities are really quite useful in terms of, the police force covers the whole area. The combined authority that funds the early warning system and the trend research that we do also funds the police. So I think it's a really good way of, that kind of ensuring that kind of cooperation. I think in terms of kind of what you do, what we found was that initially we were developing really good relationships with people, and then they'd leave. They'd get a new job, or they'd get promoted if they were any good. So it's a way of embedding those kind of, roles within, the systems, whether that's the police or kind of what have you. I think those are kind of useful pointers. And as Deb mentioned as well, this competitive kind of tendering is not helpful in terms of people cooperating and feeling as though they have to keep everything within themselves as well. But I mean, I just think it's about people being willing to share information and seeing the mutual benefits of it.
Thanks, Mike. Anything to add from any observations, Deb?
Just to reiterate what Mike said, really, we need to get over ourselves. This is a crisis, and it's only going to get worse. And we just all need to share as much information with each other as we possibly can, because we're kind of, stumbling around in the dark. Unless we share information, we can't respond properly.
Thank you. I'm going to pass over to some of the questions that have been posted while we've been chatting. So the first one I'm going to come to is from Peter Furlong. I know Peter from CGL. And Mike, it's addressed to you, really. You talked about non-opiate users being at risk. How do we communicate with children and young people services and non-opiate users about some of the harms, the alarmist information that's out there, and also some of the harms, I think, that this new wave of drugs can cause?
I think it's really difficult. I mean, treatment services are, no matter which part of the country you're in, treatment services are, they all pretty much have got this well rehearsed in terms of the sort of response to the people they see in treatment, and to a certain extent, people who are in and out of treatment, and kind of people we know are vulnerable, high risk, whatever terms you want to use. If you do get a situation where, if it's site specific, for instance, I mean, I'm a volunteer with the Loop. I've done drug checking at festivals and worked far too old now to do it, but various kind of clubs. We've got some. I'm not sure if I'm supposed to say this, but I'll say it anyway. We've got some back of house drug testing that's there's a license been granted to kind of do that both locally and in London as well. So I think there's a kind of response within a nightclub and festival situation. There's a kind of response for people who are in treatment or prison or wherever. But the much harder group to reach is that wider population, and it isn't just young people. I mean, there are fears that it can spread, and you'll get a situation where MDMA, cocaine, etc., start to become adulterated. But it's also this mass of people that are buying drugs online. The non-prescribed opiates, it's about 5% of the adult population have bought non-prescribed painkilling drugs over the internet. And I think that's much harder in terms of kind of putting that message across, having kind of contact with them. And it's, do you give everybody kind of naloxone sort of thing? So it's I don't have a, Peter, I don't have an answer other than that it's much harder.
Thank you. Just picking out some of the questions. One from Will Haydock, which is around what do we need to do if we learn from Mandrake and Weednos, which we know were information systems, what do we need in terms of a network of labs or testing across England and the UK, and how can we make that happen? An observation from Will was it feels like a bit of a patchwork quilt at the moment without a set of kind of standards, and does it need government intervention?
Yeah. First of all, you need a bit of flexibility in terms of the licenses. So there seems to be some kind of movement in terms of the Home Office license for testing is attached to a specific building or site. So there seems some movement for that in terms of what you can do at festivals and clubs and the rest of it, but it's still not sorted out. There are most university departments have got all the equipment. They've got all the kind of fancy NMR and gas chromatology machines that you would need. So I think it's given them Home Office license, reducing the price, making it easier to apply for inspection to get Home Office licenses. But the other issue is how you physically get the drugs to the lab to be tested. The system we've got in Greater Manchester, people can hand them in at the police station with a form saying they're for Mandrake and they've got crime number and the rest of it. But it's physically the police will have to transport those drugs to the lab for testing. The system Wedding Shoes, where you put it in the post, was developed in the days of legal highs. And it's, strictly speaking, it's illegal to put a controlled drug in the post and kind of like send it through. Now, these are all things that can be worked out, but a simple system of, if you've got a situation where somebody's overdosed, where there are somebody's got drugs that have had an unusual effect or they think are dangerous and the rest of it, a way of transporting those to get kind of rapid results would be really, really kind of like useful. So it's both the speed of it, because in most areas at the moment you're reliant on police forensic providers, and even their rapid system can take a couple of weeks to kind of find out what the drugs are before you get the results back. So it's having labs in place that can turn testing around really quickly, transporting them there, and the quality of those tests as well. It doesn't need to just tell you what the drug is and what the adulterant is. It needs to tell you the purity, the percentage of a particular drug that's in a pill, etc.
Do you think that's likely to happen in terms of the continuation of the drug strategy?
Well, it's like everything. I mean, at the moment, we're still waiting to hear if there's long-term funding for treatment services. So to an extent, drug testing is not cheap. So whatever system they come up with, yes, it's badly needed, but that's going to be a will to do it. a willingness to do it and providing the funding for it as well. So, but at the moment, I think they're waiting to see how this experiment with drug checking in Scotland goes, which is going to be based in their overdose prevention sites.
Thank you. A question from Jude Duncan, perhaps to you, Deb, initially. How do services need to change so that they feel relevant for people whose abstinence is not their goal? So again, talking about the importance of harm reduction in terms of what providers can do.
Thanks, Jude. That's a big question. I mean, we just need to acknowledge the fact that abstinence isn't everybody's goal. I think that's the first thing. I think one of the issues with a lot of our services is there's been a really high turnover of staff. We had a lot of really experienced staff, but because of funding cuts, we lost a lot of really experienced staff. So a lot of our staff are new, and they've come into this sector when the recovery agenda was the way that we worked. So they don't have a full understanding of harm reduction. They it's not something that's in their kind of remit, I guess. So I think staff education is a massive one. I think people like Jude and people like me that work with services need to advocate for harm reduction. And I think we do need to do a lot of staff education, because for a lot of staff, their understanding of harm reduction is very limited. It's needle exchange and naloxone. And by needle exchange, I mean giving someone some needles. And by naloxone, I mean giving someone some naloxone, not having a conversation about reducing their risk of overdose, as an example. And it is really, I've seen it so many times as an inconvenience that's getting in the way of someone completing paperwork. Staff have so much paperwork that they need to complete now, that becomes the priority, and drugs workers almost become admin workers, through no fault of their own, but they just have so much paperwork that they have to complete, and something has to give. And what tends to give is needle exchange, which to me, the needle exchange is one of the most important places in a drug service. It's where people that often don't engage with any other professionals at all get to sit down and have a conversation about what's going on for them. You have the opportunity to build really long-term relationships with people and do some really significant work with them to reduce the risk. And it needs to be prioritised again. In a dream world, it also needs to be in a different building to the treatment service. But, being realistic, we haven't got much money, so I don't think that's going to happen. But I think people that are in more senior positions in drug treatment services need to allocate staff time to be able to properly run those services and dedicate the time to them that they deserve, because they have been the poor relative for so long to the focus on positive exits. Let's get them in, get them turned around and get them out again. And we all need to reframe the way that we think about drug treatment.
Thank you. Just coming on to, because we've got a good set of questions still to get through. One from Faye Barraclough from NHS England Health and Justice team. So the question is about, have we seen any emerging themes in relation to synthetic opioids within the adult prison estate? So any intelligence or understanding of what the impact might be in the prison population?
I'm sure it's kind of been there. I'm not aware of any particular outbreak in prisons of synthetic opioids that's kind of like that's going on. They've got more testing in prisons now than they, testing of substances, not of individuals, than they kind of used to have. And obviously, everything isn't shared with me, but I mean, nothing I'm particularly aware of.
Anything, Deb, that you've heard?
No, the only thing that I'd heard about was, I mean, we know there were a few deaths in Wales, but I don't know if the outcome was that it was linked to synthetic opioids. And there was an incident in Ireland, but as far as I'm aware, although they initially believed it was synthetic opioids, it turned out that it wasn't. It was something else.
Next question I'll go to, something I was reading this morning actually, was it's from Mike Smith from Turning Point. And it's around the government announced today a number of research initiatives. I think it was £12 million worth of funding into research initiatives to reduce drug-related deaths, which obviously we welcome. The widening of access to life-saving measures requires services being attractive for people who aren't out of treatment. I think it comes back to your point, Deb. What would be some of the key measures that we'd take to reach those people who we're not seeing, who for whatever reason our services aren't attractive, we're not engaging as we should be?
Me or Deb, sorry.
Either of you.
Well, I mean, as I said, I think it's that issue of reducing stigma is a massive thing, whether that's the wider health services or when you go and pick up your methadone or buprenorphine. That's a kind of major issue. But it's, you know, it's a massive thing when you actually enter that front door, walk through a front door and kind of ask for help. This isn't a kind of casual thing. It's not like people don't like the colour of your carpets or anything as well. And it may be that it's not necessarily suitable for kind of, you know, everybody to go into, you know, some kind of treatment. So I think the idea of putting money into research and having this kind of research led is the sort of way to go with this anyway, because I don't think there's any kind of simple answers. There are some things that are being successful, but if we can do some research that's about some kind of innovation that's, you know, maybe going into a drug treatment service isn't the answer, but I mean, how do you get kind of help to people who are kind of resistant to that? But I mean, other than that, you know, you make your treatment services attractive by giving people what they want.
Thank you. Question from Emily from Turning Point in Leicester, who's new to the service. Emily's really interested to know what the future of nitazines looks like for our service users. Do we know if they're likely to continue affecting more and more drugs and becoming the norm? And how about the drugs you mentioned that younger generations are generally using more of?
I think that we don't know is the simple answer. You know, I've been following the Afghan heroin harvest or opium harvest for the last getting on 40 years, and up until quite recently, they've always been wrong in terms of what they predict. So it's complicated in that, you know, you can bury heroin underground and it improves in quality, and if the price goes up, etc., there are already new kind of markets that are open in, you know, through South Africa and kind of different things like that. So it's difficult to predict, particularly as most of the Afghan heroin is sold in Asia and Africa, and you get a much better price for it in Europe. So at the moment, you know, heroin's still out there. From the tests that we've done, it looks as though the quality's fallen a little bit, but it's still there. Added to that, it's really difficult checking Chinese legislation, you know, technical legislation on chemistry that's written in Cantonese. But apparently the Chinese have also introduced legislation on nitazines. Now, the last time they did that, they introduced legislation on fentanyl analogues, which actually led to the nitazines being produced. So I think there's a lot that we kind of don't know. In terms of the market at the moment, there are one or two, you know, experimenters and people who will actively seek out nitazines, but by and large, they're unwanted. So these are drugs that are used as adulterants. That could all change. The situation, I spoke to some people who worked in a overdose prevention site in Canada, and they were saying that Canadian market changed from being a heroin-only market to a fentanyl-only market in a space of about 3 months. So, you know, that was the only drug in town. People didn't want their heroin back. They were kind of, you know, using synthetic opioids. So, you know, you can crystal ball gaze, but we don't know.
Thank you. A related question, I guess, to that is from Randy Dansar, and it's, are services prepared to deal with large-scale use of synthetic opioids? Deb, I guess one for you at this moment in time. Are we geared up for what might be coming around the corner?
I mean, yes and no, I guess, is the answer. So, you know, services are all preparing their plans. You know, we are putting stuff in place with an expectation that this will happen. But I think when it does happen, it's a real different kettle of fish. If it's something that you've never dealt with before, to an extent that you've never dealt with before. So I don't know that services will be able to be fully prepared, but services are certainly, you know, aware that this is a risk and doing everything that we can to ensure that we meet it when it comes. But I don't think you can ever be prepared for, you know, large scale overdoses and deaths. It's just, you know, it's impossible. But I would say that we're working to be as prepared as we are. And, you know, I think I can speak for sort of all the providers. I know all the providers are doing a lot of work to make sure that they're ready if this does happen. But yeah, I don't think anyone can ever be prepared enough for you know, a large amount of overdoses all happening at once.
Thanks, Deb. We have got a hand up now. We're not able to take questions from people directly just because of how the webinar's been set up. Mark, are you able to put your question in the chat? If you would like it answering, thank you. Next question, Mike. Have we heard anything further about the changes in legislation around naloxone and the ability for even wider distribution?
They introduced the first reading of the bill in Northern Ireland, I think, last week, but I've not seen the legislation. There's no indication that, you know, it's a kind of user-friendly bill that was kind of put through, so I can't see any reason why they wouldn't do it, but I haven't seen that, you know, it being kind of drafted as first legislation yet.
Thank you. Question for you, Deb, if you're with us, is how can we involve people who use drugs who don't want to go near drug treatment services, be involved in shaping the system response to the change in drug market?
We need to go out and talk to them. We need to ask them. It's as simple as that. That's one of the real challenges, though, isn't it? Of not just involving, but, you know, but speaking to people that aren't accessing services, is finding them first, because they're not accessing services, so we don't know where they are. But if we can identify them, if we can go to the places where we think they are, then we need to talk to them, ask them what they want, ask them how they can be involved. You know, it needs to come from them, and we should be doing it as well, absolutely.
So looking through the questions, just thinking of the time, so probably one or two more. You talked earlier, Mike, about some gaps in intelligence and information, and I'm just thinking of more broadly, given the shift in government at the moment, what could government do differently to support a broader response to these changing drug threats?
Well, I mean, I think we're doing it. I think certainly the government could act with coroners. I mean, coroners are, you know, rightfully so, independent courts and the rest of it, you know, law unto themselves, whichever way you want to kind of like put it. But I think it's ridiculous that it's down to the individual whim and relationship with a coroner, whether they report to drug-related death panels or, you know, early warning systems, drugs intelligence systems, that should be, you know, it's no good just putting it in guidance. That should be part of their job. It should, you know, as in my humble opinion, keeping people's lives more important than, you know, reporting 18 months later on how they died, sort of thing. So I think that's something that you would need at a government level. Kind of at a local level, it's really working out how the systems work. It's not that there's an unwillingness. I mean, we've been meeting with a number of A&E consultants and hospital pharmacies to see what can be done within the existing data, what can be shared. You know, if people turn up at A&E departments and, you know, they've overdosed and they confiscate their drugs at the moment, they're destroyed. we're trying to develop a system where they can actually be tested, because those are the drugs you want to test, is the ones that have caused kind of overdose. But just kind of real-time information in the, you know, have you got the confidence that if 30 people died in an area, and they went to different hospitals, different A&E departments run by different trusts, would that information, you know, where would it sit? Would it be shared kind of rapidly enough? So I think that's something that's that a number of areas are kind of working on, and I think it's kind of piloting it in the real world, and seeing how it works, and then pushing that as a model of best practice rather than waiting for some kind of government legislation.
Thank you, Mike. It's 5 to 4, so we've only got 5 minutes left. So I'm just going to ask Mike or Deb if they've got any closing comments before we wrap the session up.
Other than I've got to mention nitazene strips in my talk. I think that's something that's, I mean, you know, nitazene strips are strips that drug services are now, you know, anybody can give them out, but drug services are giving them out, testing for nitazenes, fentanyl, and xylazine, which is a vet tranquilizer that we're also seeing as an adulterant at the moment. I think they're a really useful development that, you know, relies on people taking control themselves. They're not perfect. They do test false positive if the heroin's too strong or the coke's too strong. You know, they can be kind of like misused in terms of people not operating them properly. But I think that's the kind of way forward as they're kind of developed as well. So I think that's a kind of useful thing to add in. That's, you know, a kind of recent development.
Thank you. So just drawing the webinar to a close, if there are any questions that haven't been answered, we will answer them. So there'll be a recording of this session, and we will try and get answers to people that we've not managed to get to today. Back to you. We've got everybody's details who logged into the session. Just a couple of summary points. I think, you know, the importance of intelligence and information was a kind of starting point around. We really do need to know what we're dealing with and trying to address some of those gaps in information, be it from coroners, be it from NHS sources. And I think for me, the importance of a multi-agency response. So as Mike talked about the Greater Manchester example, but I think people really coming together. We talked a lot about kind of stigma and really kind of supporting and developing treatment services so that they are more attractive for people. And I think finally, one of your points, Deb, around there's never been a more important time for harm reduction, for really focusing on helping people reduce the harms that drugs cause, and actually us all working together, regardless of what the name is above our door or who we work for, but really coming together to share innovation and to share good practice.
And can I just quickly say, there's one thing that we can all do. If anyone on this call doesn't carry naloxone when you're not at work, carry naloxone. And if you think someone's overdosed, don't just walk past them, do something, call 999.
Thank you, Deb. No, thanks. Important to say. Thank you. So there will be a recording of this session for anybody who wants to watch it back or to share it with colleagues, available on our website. So please do look out for that. Thank you so much to our guests, to Mike Linnell and to Deb Hussey, and to everybody for joining on this Friday afternoon. Thank you very much.